Hi, everyone, and welcome to our Wound Care Micro Session Series. I'm Sarah Holtman, Director of Clinical Education with Wound Care University. In these short sessions, about 10 minutes or less, we'll tackle one high impact topic at a time so you can take a practical pearl back to the bedside. Today, we are focusing on electronic clinical quality measures, or eCQMs, in wound care. The purpose of this short session is to connect something that often feels abstract, quality reporting, with the daily work clinicians and staff already do in the wound clinic. CMS defines eCQMs as quality measures specified in a standard electronic format that use data extracted electronically from EHRs or health IT systems to measure the quality of care provided. That means the quality measure is only as strong as the structured data captured during routine care. For wound care teams, the practical message is simple. What we assess, choose from structured fields, document consistently, and close the loop on becomes the evidence used to evaluate quality. This session will focus on how to think about eCQMs through a wound care lens where documentation gaps occur and how to build workflows that support both patient care and quality reporting. An eCQM is not just a report, it is a standardized electronic quality measure built to use structured data from the EHR and health information technology systems. The measure logic defines who is included, who is excluded, and what counts as meeting the measure. There are three important words in the phrase electronic clinical quality measure. Electronic means the data are pulled from digital systems. Clinical means the data connect to actual care decisions or patient outcomes. Quality measure means the system is evaluating whether the care documented for a defined group of patients met a specific expectation. In practical terms, an eCQM asks, among the patients who qualify for the measure, did we do and document the expected care? If the care was done but not captured in the right place, the measure may not count it. That is why eCQMs are both a clinical quality issue and a documentation workflow issue. Wound care is highly process dependent. Patients often require vascular assessment, infection monitoring, offloading, compression, nutrition, glycemic optimization, debridement decisions, dressing changes, and close follow up. If any one of those areas is missed or inconsistently documented, healing can stall, and the record may not accurately reflect the care delivered. eCQMs matter because they give organizations a way to evaluate whether key care processes are happening reliably. They also support patient safety by highlighting gaps that might otherwise remain hidden. For example, if a diabetic foot ulcer patient has no structured documentation of vascular status, the care team may still know the limb looks perfused, but the data system cannot see that clinical reasoning. If infection signs are buried in free text, the measure logic may not count the assessment. If follow up is completed but not linked properly, quality performance may look worse than actual care. The goal is to make good care visible. This is the basic flow of an eCQM. First, the patient must qualify for the measure. That qualifying group is called the denominator. A patient might qualify because of a diagnosis, encounter, age range, procedure, or clinical condition. Second, the EHR must contain the right structured data. This may include diagnosis codes, procedure codes, medication lists, labs, orders, assessment fields, dates, and care plan elements. Third, the measure logic runs. It determines whether the patient meets numerator criteria, whether exclusions apply, and whether timing requirements were met. Finally, performance is calculated. Reports may show whether the organization passed, missed, or had incomplete data for a measure. The most important sentence on this slide is this: eCQMs evaluate data elements, not intentions. If a clinician did the right thing, but the information is not captured in a structured or reportable way, the measure may not reflect the care accurately. Wound care documentation contains many data points that may be relevant to quality reporting, even when the measure is not specific to the wound. Start with the wound assessment: etiology, size, depth, tissue type, drainage, odor, pain, peri-wound condition, and infection signs all help show severity and clinical trajectory. Next are risk and diagnostic elements. Vascular findings, ABI or arterial testing, diabetes control, nutrition status, labs, imaging, and osteomyelitis concerns all show whether the team is addressing the reasons wounds fail to heal. Treatment plan documentation is equally important. Debridement, dressing choice, compression, or offloading. Antibiotics, referrals, patient education, and follow up instructions tell the next clinician what was done and why. Finally, eCQM thinking requires follow up closure. Was the patient reassessed? Did the wound improve? Was escalation documented? Did we close the loop on referrals, abnormal labs, or worsening signs? The key principle is not to document more for the sake of more. It is to document in a way that supports care continuity and makes the work reportable. These are the most common documentation pitfalls that affect quality reporting in wound care. The first is relying only on free text. Free text is useful for clinical narrative, but quality measures often need structured fields, codes, orders, dates, and discrete results. The second is timing. Many measures have specific windows. If the assessment happens but is documented late, the system may not count it. Third is missing closure. For example, documenting that a vascular referral was recommended is not the same as documenting that the referral was placed, discussed, followed, or addressed. Copy forward is another issue. It saves time, but it can also create conflicting wound details, especially when measurements, drainage, and tissue type change. Role confusion is very common. The provider may assume nursing documented education. Nursing may assume the provider documented medical decision making. The result is a gap. Finally, non-standard wording creates reporting problems. If one person writes rubor, another writes redness, another writes erythema, and another writes inflamed margins, the clinical meaning may be similar, but reports may not recognize the pattern. Standard language helps. This slide is intentionally framed as quality themes rather than a list of specific measures. Measures change, and CMS updates eCQM specifications annually. That means teams should always verify the current measure requirements for the applicable reporting or performance period. Even when a measure is not called a wound care measure, it may still affect wound patients. Diabetes measures are relevant because many patients have diabetic foot ulcers or delayed healing related to glycemic control. Vascular risk themes matter because perfusion is central to lower extremity healing. Infection and safety measures connect to timely escalation, antibiotics, cultures, and systemic signs. Prevention and recurrence measures connect to smoking cessation, nutrition, compression, offloading, fall risk, and patient education. Care coordination measures are also important because wound care often depends on referrals and communication across disciplines: vascular, podiatry, infectious disease, primary care, endocrinology, home health, and durable medical equipment. The takeaway is that wound care teams should understand the quality ecosystem around the patient, not just wound specific documentation. The best way to improve eCQM readiness is to build quality thinking into the visit workflow. It should not be a separate audit project that happens weeks later. Before the visit, staff can confirm the reason for the appointment, open orders, missing labs, prior vascular studies, and whether there are quality items that need to be addressed. During assessment, the nurse or clinician should use structured fields whenever possible. Wound measurements, tissue type, drainage, signs of infection, pain, peri, wound status, and offloading or compression adherence should be updated accurately. During the provider plan, assessment findings should connect to medical decision making. If the wound is worsening, the plan should reflect the response: imaging, labs, antibiotics, vascular referral, debridement, advanced therapy consideration, or follow-up timing. At checkout and follow-up, the team should close the loop. Did the patient receive education? Were return precautions documented? Is the next appointment scheduled? Is someone tracking the referral or abnormal lab? The rule is simple. If the data will matter later, capture it correctly during the encounter. This micro challenge is designed for group discussion. The patient has a diabetic foot ulcer and now has increased drainage and new peri-wound redness. The nurse documents the change in narrative text. The provider orders antibiotics and says vascular referral may be needed. The patient is told to return in 1 week. Ask the group what information should be structured. Examples include wound measurements, drainage amount, drainage type, peri-wound redness, pain, infection signs, and whether there are systemic symptoms. Next, ask what care gaps need closure. If vascular referral may be needed, was it actually placed? If antibiotics were ordered, was the indication documented? Was the patient educated on warning signs? Was follow-up timing appropriate given worsening signs? Ask what should be escalated today. New redness and increased drainage could require infection assessment, possible culture if criteria are met, antibiotics, close follow-up, and possibly earlier reassessment than 1 week, depending on severity. Finally, ask who owns each documentation item. This is where teams often discover the real gap. The nurse owns structured wound assessment. The provider owns medical decision-making and orders. The checkout or coordinator may own follow-up and referral tracking. Everyone owns communication. Let's close with 5 takeaways. First, eCQMs measure structured data, not good intentions. If care is not captured in a way the system can use, it may not count. Second, wound care quality depends on complete assessment, timely escalation, and closed-loop follow-up. These are not separate from patient care. They are part of safe wound care. Third, standard language and role clarity reduce documentation gaps. Teams should agree on who documents wound assessment, who documents medical decision-making, who tracks referrals, and who closes education and follow-up. Fourth, measure specifications change annually. CMS updates eCQM specifications to align with current clinical guidelines and code systems, so organizations should use current eCQI and CMS resources for the reporting year. Finally, better data supports better care. The goal of eCQM work is not to click boxes for the sake of compliance. The goal is to make high-quality, evidence-informed care visible, repeatable, and improvable. Thank you for attending this wound care micro session. We value your commitment to patient care. We'll be back with another focused topic soon. Don't forget to like and subscribe. See you next time.